So I want you to imagine a patient sitting across from you in your clinic.
Okay, setting the scene. I like it.
Right. And they've been on the absolute maximum dose of sertraline,
Mm.
Zoloft, for, man, over a year now.
Which is a super common scenario.
Exactly. And structurally, you've made some progress.
Mm.
The daily debilitating panic attacks that originally brought them in, those are mostly gone.
Right, the autonomic spikes are blunted.
Yeah, they aren't waking up drenched in sweat quite as often.
Yeah.
But, and here's the kicker, as you look at them, you realize they're just emotionally dead.
Completely flat.
Completely flat. They describe themselves as, like, existing behind this thick pane of glass.
Yeah, the classic emotional blunting.
Right. And they are profoundly exhausted.
Mhm.
But at the same time, their baseline startle response is still just through the roof.
Like if you drop a pen, they jump.
Exactly. If
Yeah.
someone drops a book in the waiting room, they literally jump out of their chair. And they're on the absolute verge of just, giving up on treatment entirely.
Yeah, that clinical picture right there, that is honestly one of the most frustrating, heartbreaking scenarios a prescriber faces.
It really is.
And it happens every single day in clinics everywhere.
Which is exactly why we're here.
Yeah.
Today, we are not talking about your standard issue first-line Band-Aids.
No, we're moving way past that.
If you are listening to this deep dive, you're a practitioner. You're a psychiatric mental health nurse practitioner, a psychiatrist, a clinical specialist, and you are staring at a patient whose neurobiology has been completely fractured by trauma.
And the standard playbook has totally failed them.
Right. So we are unpacking the heavy artillery today.
Mhm.
Our mission for this deep dive is mastering a highly potent intervention for that exact patient. Venlafaxine Effexor.
And just to define our scope right out of the gate, we are going to strictly focus on the pharmacology, the dose-dependent mechanics, and the strategic clinical decision-making surrounding venlafaxine Effexor in severe PTSD.
So no basic diagnostic criteria today.
Exactly. We are entirely bypassing the general theory of trauma. You already know what PTSD looks like.
All right, you live it every day in practice.
We need to focus purely on the neurobiology of specific treatment-resistant symptom domains, and specifically how this one particular molecule alters those domains at the actual receptor level.
I think the most dangerous trap a clinician can fall into is treating venlafaxine Effexor like it's just, a slightly stronger SSRI.
Oh, completely. It's a totally different animal.
It really is. I always like to use this analogy. It's like a multi-stage rocket.
I love that analogy. It fits perfectly.
Right. Because it actually changes its mechanism of action, its very chemical nature in the brain, depending entirely on how much fuel or dosage you give it.
And if you don't understand those specific stages, you are going to underdose your patient.
Exactly. You expose them to all the side effects, and you get absolutely zero clinical benefit for the symptoms that are actually ruining their life.
Yeah, you just give them the worst of both worlds.
So let's start by contextualizing the role of SNRIs, serotonin, and norepinephrine reuptake inhibitors in PTSD. Because right now, the FDA and most major treatment guidelines, they position SSRIs as the golden children.
Right, sertraline, Zoloft, and paroxetine Paxil.
Yeah, those are literally the only two FDA-approved medications for PTSD.
And to be fair, for good reason initially,
Sure. Okay.
SSRIs possess a really wide margin of safety, and they're generally well tolerated by the broader population. And they do effectively dampen that core generalized fear response.
Yeah.
They elevate serotonin in the synapse, which, eventually leads to the downregulation of certain postsynaptic receptors.
Which basically turns the volume down on the brain's alarm system.
Exactly. But that ceiling effect you just described in your opening vignette, that is incredibly common.
The patient survives, but they don't thrive.
Precisely. SSRIs frequently leave patients with these debilitating residual symptoms. They just hit a brick wall when it comes to profound, lingering, trauma-induced fatigue.
Well, the fatigue is massive.
It is, and they often exacerbate that emotional numbing, that terrible feeling of being detached or trapped behind a glass.
Right.
And crucially, SSRIs often fail entirely to resolve severe hyperarousal. The patient's baseline vigilance just remains way, way too high.
So to rescue a patient from those specific stubborn domains relying solely on serotonin is just a losing battle.
It is. We absolutely must recruit norepinephrine.
Okay, wait, I have to stop you right there.
Okay.
Because my clinical intuition screams that this is a massive paradox.
Oh, so?
Well, PTSD fundamentally involves a profoundly dysregulated, overactive noradrenergic system, right?
Right.
The patient's central nervous system is stuck in fight or flight. They are practically soaking in central adrenaline.
Hmm.
The locus coeruleus is firing nonstop.
That's the exact pathology, yeah.
So why on earth would we prescribe a drug that purposely boosts norepinephrine?
Yeah,
I mean, doesn't that risk throwing gasoline on an already raging fire?
it's such a logical question.
I would think that blocking norepinephrine reuptake would just make their hyperarousal infinitely worse.
And you're not alone in thinking that. Early psychopharmacologists had the exact same concern, and history actually proved your apprehension to be completely logical.
Wait, really? How?
Well, in the early days of treating trauma, researchers looked at the noradrenergic system and hypothesized that perhaps manipulating it directly would help. So they tried using drugs like dicipramin, norpramin.
Ah, okay, the older tricyclic antidepressant.
Exactly. And dicipramin, norpramin, acts as a highly potent, relatively pure norepinephrine reuptake inhibitor.
So it boosts norepinephrine without really touching the serotonin.
Right. It doesn't provide much serotonergic support at all. And the result, it was a complete clinical failure for PTSD.
Oh,
It exacerbated anxiety. It failed to provide the mood-stabilizing relief patients desperately needed. And it essentially did exactly what you just feared. It threw gasoline on the fire.
okay, so if a pure norepinephrine boost is a failure, how does venlafaxine Effexor escape that trap? Like, why does a modern SNRI succeed where dicipramin, norepinephrine, failed so spectacularly?
It all comes back to your multi-stage rocket analogy.
Ah, the dose dependency.
Exactly. Venlafaxine Effexor succeeds because of its dose-dependent pharmacology. It doesn't just dump norepinephrine into the system indiscriminately right from the start.
Right.
It provides a massive foundational layer of serotonin reuptake inhibition first. It stabilizes the generalized fear response and raises the floor on the patient's depressive symptoms before it ever begins to meaningfully modulate norepinephrine.
So the serotonin basically acts as the heat shield, allowing the rocket to accelerate safely.
That is a perfect way to conceptualize it.
Let's dissect that multi-stage mechanism then, because this really is the core of mastering the drug. We need to break down these stages of receptor pharmacology based on the actual dose the patient is swallowing.
Let's do it.
Walk us through stage 1.
So stage 1 is the low-dose territory. Clinically, we're looking at 37.5 milligrams to 75 milligrams a day.
Okay, standard starting doses.
Right. At this level, venlafaxine Effexor has a very high affinity for the serotonin transporter, or SERT. It binds to those pumps and blocks them, keeping serotonin in the synapse longer.
Makes sense.
But crucially, at 75 milligrams, its affinity for the norepinephrine transporter, the NET, is clinically negligible.
Wait, really? It doesn't touch it at all?
It simply cannot compete for those receptors yet. So, at 75 milligrams, venlafaxine Effexor functions almost exclusively as an SSRI.
Okay, this is a critical point for the listener to internalize. If you are keeping your patient at 75 milligrams of venlafaxine Effexor for months, you are not giving them an SNRI.
No, you're not.
You are basically giving them a very expensive SSRI that happens to have a notoriously terrible half-life and worse withdrawal symptoms than sertraline, Zoloft, or paroxetine Paxil.
That is exactly the trap so many prescribers fall into. You are exposing the patient to the risks of the medication without ever unlocking its unique benefits.
Wow. Okay, so what about stage 2?
Stage 2 is the moderate to high doses. This is where we cross that 150 milligram threshold and move up to around 225 milligrams.
Okay, so we're pushing the dose up.
Right, and at this concentration, the drug finally achieves robust engagement with the norepinephrine transporter.
So it finally starts acting like an SNRI.
Exactly. It binds to the NET, inhibiting the reuptake of norepinephrine, allowing it to actually accumulate in the synaptic cleft. This is the moment the dual action truly begins.
The second stage of the rocket fires.
You got it.
But there is a third stage, right? The heroic doses. What happens when we push past 225 milligrams?
Stage 3 involves what we call heroic dosing, which ranges from greater than 225 milligrams all the way up to 375 milligrams.
That is a serious dose.
It is. And at these highly elevated plasma levels, venlafaxine Effexor does something entirely different. It begins to weakly but meaningfully block the dopamine reuptake pump, the D8.
Okay, here is where my mind was completely blown when I was synthesizing the underlying neurology for this.
Oh, the prefrontal cortex dynamics.
Yes, because the dopamine boost isn't just this generalized flooding of the entire brain. There's a fascinating anatomical quirk in the human brain, specifically in the prefrontal cortex, that makes this stage 3 mechanism incredibly elegant.
Yeah, you are referring to the dopamine dynamics in the dorsolateral prefrontal cortex.
Right. Walk us through that because it's wild.
So the architecture of the brain is highly specialized. In regions like the striatum, which is heavily involved in reward and movement, there are millions of dopamine transporters, the DATs.
Right. Their sole job is to clean up excess dopamine.
Exactly. But in the prefrontal cortex, which is the brain's executive control center, DATs are surprisingly scarce.
Like almost non-existent, right?
They are functionally almost non-existent.
So, if there are no dopamine transporters in the prefrontal cortex, how does the brain clear out the dopamine after a neuron fires? It can't just sit there forever.
Right, gets swept up by the neighboring system. In the prefrontal cortex, the norepinephrine transporter, the NET, essentially performs double duty.
Wow.
Because the NET cannot easily distinguish between the chemical structure of norepinephrine and dopamine, it acts like a universal vacuum cleaner for both neurotransmitters in that specific region.
So it's sucking up dopamine even though it's technically a norepinephrine pump.
Exactly. Therefore, when you give a patient a high dose of venlafaxine effexor, say 225 to 375 milligrams, you are forcefully blocking that NET vacuum cleaner.
And the downstream effect of blocking that vacuum is that you are simultaneously pooling both norepinephrine and dopamine,
Yes,
specifically and surgically in the prefrontal cortex.
precisely. You are boosting dopamine exactly where the traumatized brain desperately needs it, for executive function, working memory, and sustained attention.
And without indiscriminately flooding the brain's primitive reward pathways, which could, lead to massive agitation or addiction liability.
Right, it's highly localized.
Before we talk about what this actually looks like in the patient's behavior, I want to clarify something about the metabolism of this drug, because it kind of dictates how these stages unfold in real time.
Sure.
Venlafaxine effexor isn't entirely doing this work alone, is it?
No, not at all. It relies heavily on the liver. When a patient takes venlafaxine effexor, it passes through the liver and is metabolized primarily by the CYP2D6 enzyme. And this enzyme converts the parent drug into its major active metabolite, desvenlafaxine, Pristiq.
Which is actually available as its own standalone prescription drug now.
It is, yeah. Desvenlafaxine, Pristiq, is its own distinct entity with its own patent. Both the parent drug, venlafaxine effexor, and the metabolite, desvenlafaxine, Pristiq, have dual SNRI action.
Okay, but is there a difference in how they hit the receptors?
There is. Desvenlafaxine, Pristiq, has a slightly different fixed ratio of SERT to NET inhibition.
Oh, interesting.
So the clinical takeaway here is really understanding polymorphic variants.
Break that down for us.
If you have a patient who is a poor metabolizer at that CYP2D6 enzyme, meaning their liver lacks the ability to efficiently convert venlafaxine to desvenlafaxine, they will have a massive buildup of the parent drug.
Right, because it's just sitting there unmetabolized.
Exactly. Conversely, an ultra-rapid metabolizer will convert almost all of it to desvenlafaxine Pristiq immediately.
So how does that affect what we see in the clinic?
This variance explains why one patient might feel the activating norepinephrine effects at, say, 150 milligrams, while another patient might not feel that same activation until you push them to 225 milligrams or even higher.
Ah, because the ratio of parent drug to metabolite in their specific bloodstream is constantly shifting the goalposts.
Exactly.
Which means we really cannot treat the dosing guidelines as absolute gospel. We have to treat the patient's actual clinical presentation.
100%. Treat the patient, not the textbook.
So let's map all of this receptor science directly onto that patient sitting in our clinic. If we achieve this top-tier stage, if we successfully boost norepinephrine and dopamine in the dorsolateral prefrontal cortex, how does that solve the clinical paradox we started with?
Right, the hyperarousal paradox.
Yeah, like how does giving them more norepinephrine actually calm their hyperarousal?
We have to shift our perspective from the total amount of neurotransmitter to the location of the neurotransmitter. PTSD is indeed characterized by central noradrenergic dysregulation. The amygdala is constantly misinterpreting safe stimuli as life-threatening.
Right, it's a broken fire alarm.
And it signals the locus coeruleus to dump indiscriminate adrenaline into the body. That is the panic. That is the exaggerated startle response.
Yeah.
But what high-dose venlafaxine effexor does is radically different. By strategically enhancing dopamine and norepinephrine purely in the prefrontal cortex, you are fundamentally bringing the brain's CEO back online.
Wow. You are strengthening the top-down cognitive control.
Exactly. The prefrontal cortex is responsible for logic, context checking, and regulating raw emotion.
Which is exactly what trauma degrades.
Right. When it is starved of dopamine and norepinephrine, as is so often the case in chronic trauma and subsequent depression, it just goes offline. It cannot tell the amygdala to stand down.
So by bathing the prefrontal cortex in these specific catecholamines, you empower it to exert top-down inhibitory control over the amygdala.
You've got it.
So, okay, let me make sure I'm visualizing this right. When the book drops in the waiting room, the amygdala still fires and says, gunshot, danger.
Yep, the initial startle is still there.
But a fully fueled prefrontal cortex can instantly intervene and say, no, look at the context. We are in a doctor's office. That is a heavy medical textbook. Stand down.
That is the exact mechanism in action. You aren't just adding random adrenaline to a panic system. You are supplying the regulatory center of the brain with the precise neurochemical fuel it needs to shut off the panic alarm.
That is incredible.
And this translates to profound clinical shifts. The patient's physical and mental fatigue begins to lift, their daytime sleepiness evaporates.
You can actually focus at work again.
Exactly. Their concentration improves. And most critically, because their brain can now properly contextualize threats, their severe hyperarousal and exaggerated startle responses begin to normalize.
I want to paint a picture of how this changes the actual trajectory of psychiatric treatment. Let's look at the patient from my opening scenario.
Okay, the one on Max Sertraline Zoloft.
Right. They're sedated, their panic is muted, but they are just surviving, not living. They show up to trauma-focused psychotherapy. Let's say they're doing prolonged exposure therapy or EMDR, and they just can't engage.
It's too much for them.
Yeah, they're too emotionally blunted to process the trauma and just way too exhausted to do the difficult cognitive work that EMDR demands.
That patient is totally stalled out. Psychotherapy for trauma requires an immense amount of cognitive energy.
Right.
Now contrast that with a patient who has been successfully titrated to an optimized SNRI dose of Venlafaxine effexor.
The stage 2 or 3 patient.
Exactly. Because their prefrontal cortex is heavily recruited, they have their executive function back. They are not sedated, they are sharp.
They aren't emotionally blunted anymore.
Right. They actually have the bandwidth to feel an emotion and process it without being utterly destroyed by it. They become an active, engaged participant in their psychotherapy.
But, and this is a big state, but getting them from that stalled, exhausted state to that optimized, engaged state requires running a very delicate pharmacological gauntlet.
It definitely does. It's an art.
Which brings us to the actual art of prescribing,
Yeah.
the dosing, the titration strategy, and the critical importance of the formulation.
Okay, let's get into the weeds here.
If I am a prescriber and I have decided, Venlafaxine effexor is the right move for this patient, what is the exact protocol? Like, how slow do we actually have to go, considering we are trying to ease a highly sensitized, traumatized nervous system into a totally new chemical state?
You must start low and go incredibly slow.
How low?
The standard starting dose is 37.5 milligrams. Because the central nervous system of a trauma patient is already hypervigilant, if you flood it too quickly, they will experience severe somatic side effects.
Like what?
Intense nausea, massive jitteriness, a really uncomfortable spike in anxiety, and if that happens, they will immediately discontinue the drug.
Right, they'll just throw the bottle away.
Exactly. So for some general depression patients, you might initiate at 75 milligrams, but in the specific PTSD population, 37.5 milligrams is much safer.
And we are using the extended release formulation exclusively, right? Like, is there any scenario where a prescriber should be writing a script for immediate release Venlafaxine effexor in 2026?
Absolutely not.
Okay, definitive answer.
The immediate release, or IR, formulation should be considered entirely obsolete in this context.
Why is this so bad?
Because the IR formulation creates rapid, aggressive spikes and drops in blood plasma levels. These extreme pharmacokinetic peaks cause unacceptable nausea, intense activation, and a brutal daily cycle of mini withdrawals as the drug washes out of their system before their next dose.
Oh, sounds miserable.
It is. The extended release, or XR formulation, uses a specialized delivery system that smooths out that curve.
It flattens it out.
Right. It allows for once daily dosing, deeply mitigates the gastrointestinal hit, and provides a much more stable baseline of receptor occupancy.
Okay, so we've started them on 37.5 milligrams of Venlafaxine effexor XR. We've bypassed the worst of the initial nausea. What is our titration cadence? When do we actually move them up?
Well, the standard textbook psychiatric guidelines suggest increasing by 75 milligram increments every 4 to 7 days.
That feels pretty fast for a trauma patient.
And in my clinical experience with severe trauma, it is often too aggressive.
Mm-hmm.
You are much better off waiting 1 to 2 full weeks between those jumps.
Okay, so slower is better.
Yes. You move them to 75 milligrams, you let them stabilize for a couple of weeks, you assess for tolerability, then you move them to 150 milligrams.
And 150 milligrams is where we start to see the net engagement, like we talked about, stage 2.
Correct.
But is that the destination? If the clinical trials for PTSD showed efficacy, where did they find the highest rate of actual remission, not just, a slight reduction in symptoms?
The therapeutic range for severe anxiety and PTSD typically spans from 150 milligrams to 225 milligrams. But the data is crystal clear here. The remission rates in the clinical trials were definitively highest at the maximum standard daily dose of 225 milligrams.
Okay, and this is where prescribers commonly fail, isn't it?
Huge pitfall. They get the patient to 150 milligrams. The patient says, hey, I feel a little better. My mood is a bit brighter.
But they're still crippled by daytime hyperarousal and fatigue,
Exactly.
right? And the prescriber thinks, well, the drug kind of worked, but not enough. Time to switch to something else, or maybe time to augment with an atypical antipsychotic. But that's the wrong move.
It is entirely the wrong move. If a patient is a partial responder at 150 milligrams, your absolute next clinical step is to push the dose. You must titrate them to 225 milligrams.
Because you need that norepinephrine.
Right. You have to ensure you are aggressively occupying enough of those norepinephrine transporters to guarantee that dual action. You don't abandon the trial when you haven't even utilized the full capacity of the drug.
Let me play devil's advocate for a moment, though.
Go for it.
Because earlier you mentioned stage 3, the heroic dosing up to 375 milligrams. And Stahl's Essential Psychopharmacology even notes that specialists sometimes push up to 600 milligrams for extreme treatment-resistant cases.
Yes, they do.
If I'm sitting in a clinic, you are telling me to push a severely traumatized, highly anxious patient with probable autonomic nervous system dysfunction to 375 milligrams of a powerful SNRI. I mean, aren't we just begging for a massive hypertensive crisis?
It's a very real concern.
Aren't we risking a manic flip? Why on earth would I take that massive risk instead of just taking the safer route and augmenting their current 150 milligram dose with, say, a low dose of aripiprazole, Abilify, or quetiapine, Seroquel? What justifies pushing Venlafaxine Effexor into the stratosphere?
That is exactly the critical thinking a prescriber needs to utilize. You're weighing the risks. Yes, pushing to 375 milligrams or beyond carries significant risk. It requires meticulous cardiovascular monitoring, which we will definitely cover in depth shortly.
Right.
But the justification lies in the receptor mechanics. Augmenting with an atypical antipsychotic like quetiapine, Seroquel, is going to introduce heavy sedation, metabolic risks, massive weight gain, and it will likely worsen their daytime fatigue.
It basically acts as a chemical restraint.
Exactly. You're just sedating the problem. By contrast, pushing Venlafaxine Effexor to 375 milligrams is attempting to recruit that final stage, the dopamine reuptake inhibition in the prefrontal cortex.
You're making a calculated bet.
You're making a calculated bet that the patient's treatment resistance is rooted in a profound deficit of executive function and prefrontal catecholamines. If you get it right, you don't sedate them. You wake them up. You restore their cognitive architecture.
Wow.
It is an advanced maneuver reserved for specialists when all other standard options have been exhausted, but it is a vital tool precisely because it targets the deficit rather than just sedating the symptom.
That makes perfect sense. It's the difference between numbing the brain and actually repairing the brain's regulatory circuits.
Well said.
But let's rewind to the very beginning of this process. The reality of clinical practice is that patients rarely walk into your office completely unmedicated.
Almost never.
The vast majority of the time, they're currently taking an SSRI that isn't working. How do we practically execute the switch from an SSRI to Venlafaxine Effexor? We can't just tell them to stop taking sertraline Zoloft on Monday and start 75 milligrams of Venlafaxine Effexor on Tuesday, can we?
No. That would be a catastrophic clinical error.
What happens if you do that?
Abruptly stopping an established SSRI will plunge the patient into SSRI discontinuation syndrome.
Which is awful.
It's characterized by severe flu-like symptoms, vertigo, and extreme emotional lability. And at the exact same time, you'd be introducing a new, highly activating medication.
So they're withdrawing from one while getting the side effects of another.
Exactly. The patient would be utterly miserable, they would blame the Venlafaxine Effexor, and they would abandon the trial immediately.
Except maybe in the case of fluoxetine, Prozac,
Ugh.
because it has that incredibly long half-life.
Right. Fluoxetine Prozac is the outlier due to its massive half-life. It essentially tapers itself over several weeks.
So you could technically just stop it.
Well, even with fluoxetine, Prozac, you have to proceed with extreme caution because fluoxetine is a potent inhibitor of the very CYP liver enzymes, specifically CYP2D6, that venlafaxine effexor requires to metabolize into desvenlafaxine prostique.
Oh, right, the metabolism bottleneck.
Exactly.
Yeah.
If you start venlafaxine while fluoxetine is still heavily in their system, you risk massive spikes in the parent drug and potentially trigger serotonin syndrome.
Dangerous. So what do we do for the other SSRIs?
For virtually every other standard SSRI like sertraline, Zoloft, Proxetine, Paxil, citalopram, Celexa, we utilize a highly controlled cross-taper.
The Maudsley prescribing guidelines lay this out beautifully. I look at the cross-taper like passing a baton in an Olympic relay race.
Oh, I like that.
You have the SSRI runner coming in and the venlafaxine effexor runner taking off. If the SSRI runner drops the baton completely before the venlafaxine runner has a firm, tight grip on it, the patient's serotonin levels crash and they fall into severe withdrawal.
That is an excellent way to conceptualize it. You must provide continuous serotonergic support during the switch.
So what does that baton pass look like in practice? Day by day.
The practical application looks like this. Let's assume your patient is on a standard dose of 100 milligrams of sertraline Zoloft.
Okay.
Step 1 is to have the dose of the current SSRI. You drop them down to 50 milligrams of sertraline Zoloft.
Right.
And on that exact same day, you introduce the lowest dose of venlafaxine effexor XR, which is 37.5 milligrams. You hold them there for 1 to 2 weeks.
So they are taking both medications simultaneously, but at lower non-toxic levels.
Correct. The 50 milligrams of sertraline Zoloft prevents the withdrawal crash, while the 37.5 milligrams of venlafaxine effexor begins occupying the SERT receptors, allowing the central nervous system to acclimate to the new molecule without being overwhelmed by its noradrenergic properties.
And then what?
After that stabilization period, you withdraw the final 50 milligrams of sertraline Zoloft completely, while simultaneously bumping the venlafaxine effexor up to 75 milligrams.
The baton has been successfully passed.
Exactly. You can then continue your upward titration of the venlafaxine effexor to your therapeutic targets of 150 or 225 milligrams safely.
Speaking of dropping the baton and plunging into withdrawal, we absolutely must dedicate serious time to the physical toll this medication can take.
Yes, we have to talk about the risks.
Because as brilliant as this multi-stage mechanism is, venlafaxine effexor demands a level of clinical respect and vigilance that frankly exceeds most standard antidepressants.
It really does. It is not a drug for casual prescribers.
Let's look at the side effects, the risk profile, and the universally dreaded discontinuation syndrome.
The side effect profile is robust, and it requires aggressive, proactive management from the clinician.
What are the big ones early on?
When you initiate the drug, the massive serotonergic push often causes nausea. Because there are a vast number of serotonin receptors in the gut, flooding them causes gastrointestinal distress.
But usually fades, right?
It does, usually within a week or two as the receptors downregulate. You will also see early activation, a feeling of jitteriness or restless energy, which is why patient education is paramount. They need to know this is a temporary adjustment phase, not a permanent worsening of their anxiety.
We also see profuse sweating, which is highly common with SNRIs.
They're very common.
And of course, the standard SSRI side effects like sexual dysfunction, anorgasmia, delayed ejaculation, or impotence. But those are mostly quality of life issues. There is a physiological metric that we absolutely must track because we are artificially pushing norepinephrine. Let's talk about blood pressure.
This is completely non-negotiable.
Break down why.
Norepinephrine is a potent vasoconstrictor. When you block the norepinephrine transporter and pool norepinephrine in the synapses, it binds to alpha-1 adrenergic receptors on the smooth muscles lining the blood vessels.
Causing them to contract.
Exactly. It causes them to contract, which increases vascular resistance. Consequently, venlafaxine effexor is known to cause sustained dose-dependent increases in both diastolic and systolic blood pressure.
But wait, let's look at the reality of treating severe PTSD in a clinic. These patients exist in a state of chronic hyperarousal. They already have white coat syndrome.
Oh, absolutely.
Their baseline anxiety is inducing transient hypertension all the time. How do you, as a clinician, know if the high blood pressure reading you just took in your clinic is caused by the venlafaxine effexor vasoconstriction, or just the fact that they had a panic attack in the waiting room?
That is the exact diagnostic challenge. You really cannot rely on a single clinic reading.
So what's the protocol?
You must instruct the patient to monitor their blood pressure at home, in a rested state, at various times of the day, and log the results. We are looking for a sustained elevation, not transient spikes.
At what dose does this become a major concern?
This risk becomes highly statistically significant once you cross the 225 milligram threshold. If you push a patient to 300 or 375 milligrams, you must be reviewing their blood pressure logs weekly.
And if you confirm a sustained dangerous spike, what is the clinical move? Do you just yank the medication?
Well, the clinician is faced with a really critical choice here. If the patient is achieving massive psychiatric relief, if their nightmares have stopped, their executive function is restored, and they finally feel human again, you do not necessarily pull the drug.
You don't.
Not right away. You may choose to treat the newly induced hypertension with a secondary medication, like a beta blocker or an ACE inhibitor.
Ah, so you essentially accept the side effect in exchange for the psychiatric rescue.
Exactly. However, if the psychiatric benefit is only marginal, the correct move is to reduce the dose of the venlafaxine effexor or switch medications entirely. You cannot ignore the cardiovascular strain.
Okay, let's move to what I think is the most infamous, globally recognized aspect of venlafaxine effexor. If you go on any patient forum, any psychiatric subreddit, this is literally what everyone talks about, the discontinuation syndrome.
It is legendary, and unfortunately, it is entirely real.
Yeah.
Venlafaxine effexor has arguably one of the highest risks for severe, incapacitating withdrawal symptoms of any modern antidepressant on the market.
Why is it so much worse than the others?
The pharmacokinetic reality is that venlafaxine effexor, even in its XR formulation, has a relatively short half-life. It washes out of the body incredibly fast.
Let me introduce a realistic clinical vignette to illustrate just how fast and brutal this can be. I know practitioners see this constantly in the emergency room.
Oh, ER docs know this well.
Right. So you have a patient. They have been doing incredibly well on 225 milligrams of venlafaxine effexor XR for a year. The trauma therapy has integrated beautifully. The dopamine in their prefrontal cortex is firing. Their life is back on track.
A total success story.
Exactly. But they wake up on a Friday morning and decide, hey, I'm cured. I feel amazing. I don't need to be tied to these pills anymore. So without consulting you, they dump their bottle in the trash.
Which patients do all the time.
Right. By Sunday afternoon, exactly what does that patient look like physically and neurologically?
By Sunday afternoon, that patient is in absolute physiological crisis. They are likely in the emergency room.
What are they experiencing?
Because the drug cleared their system so rapidly, their massive network of serotonin and norepinephrine receptors, which have downregulated and adapted to the presence of the drug over the past year, are suddenly starved.
Just completely empty.
Yes, the patient will experience profound, room-spinning vertigo. They will be aggressively nauseous, likely vomiting. They will exhibit severe emotional lability, just bursting into tears or experiencing terrifying surges of panic and irritability.
And then there's the hallmark symptom.
Yes, but the most disturbing symptom, and the one that actually sends them to the ER convinced they are dying, is a severe sensory phenomenon commonly referred to as brain zaps.
I want to spend time on the brain zaps because patients describe them with sheer terror, and clinicians often just brush them off as, oh, it's just discontinuation symptoms.
Which is incredibly invalidating for the patient.
What is actually mechanically happening when a patient experiences a brain zap? Why do they feel an electric shock running through their skull?
It is a profound disruption of sensory integration. While the exact neurobiology isn't perfectly mapped yet, we know that serotonin is deeply involved in modulating sensory input across the central nervous system, particularly involving the cranial nerves. When serotonin levels plummet precipitously, the brain's ability to smoothly gate and process sensory information just misfires completely.
So it's a sensory glitch.
Exactly. Patients report that simply shifting their gaze, moving their eyes from left to right, triggers a literal sensation of an electrical discharge originating in the center of their brain and shooting down their neck or into their extremities.
That sounds terrifying.
It is accompanied by a momentary lapse in consciousness or a loud internal buzzing sound. It is incredibly disorienting. When a patient experiences this alongside intense vertigo, they naturally assume they are having a stroke or a massive neurological event.
So the ER doctor runs a CT scan, finds nothing, realizes they abruptly stop venlafaxine effexor, and just tells them to go take their pill.
Which fixes it, but the trauma of the withdrawal is already there.
Right. But how does the expert clinician proactively manage this risk? More importantly, how do you actively deprescribe when it is actually time, medically and therapeutically, to take a patient off the medication safely?
It begins on day one of prescribing, relentless, uncompromising patient education.
You have to scare them a little bit.
You really do. They must understand that missing even a single dose by 12 hours can trigger early withdrawal symptoms. They can never, under any circumstances, stop abruptly.
And when you do taper,
When you both agree it is time to taper, the taper must be excruciatingly slow. I cannot emphasize this enough. For sensitive patients, standard dosage drops are just too severe.
so how granular do you get?
You will literally have patients opening the XR capsules and removing a few individual microbeads of the medication every single week, stretching the taper out over 6 months or more to trick the brain into adapting without triggering the sensory shock.
That is dedication. But there is also a brilliant pharmacological workaround, highlighted in our source material, specifically in Stahl's guidelines, for patients who simply cannot tolerate even a microtaper.
The fluoxetine bridge.
The fluoxetine bridge. Walk us through the exact mechanics of this bridge.
The fluoxetine bridge is an elegant use of pharmacokinetics to basically pad the patient's neurological landing. If a patient is down to 75 milligrams or 37.5 milligrams of venlafaxine Effexor, and they cannot make that final drop to zero without experiencing severe brain zaps and vertigo, you pause the taper.
Okay.
You introduce a low dose, typically 10 to 20 milligrams of fluoxetine Prozac.
Because, as we discussed earlier, fluoxetine Prozac has that massive multi-week half-life.
Exactly. You give them the fluoxetine Prozac concurrently with their low dose of venlafaxine Effexor for a week or two. This allows the fluoxetine to fully saturate the serotonin receptors, providing a massive, stable, long-lasting baseline of serotonergic support.
And then?
Once that baseline is established, you abruptly discontinue the remaining venlafaxine Effexor.
Oh, you just stop it cold.
Yes. The venlafaxine washes out quickly, but the patient feels no withdrawal because the fluoxetine is essentially holding the receptors hostage, keeping them satisfied.
That is brilliant. And then how do you get them off the fluoxetine Prozac? Do you have to taper that?
You simply tell them to stop taking it.
Just stop.
Just stop, because the active metabolite of fluoxetine, Prozac, called norfluoxetine, takes weeks to leave the body. The drug essentially tapers itself. The concentration drops so microscopically day by day that the brain's receptors have ample time to upregulate and adjust perfectly naturally.
The patient glides down to zero without ever experiencing a single brain zap.
Exactly. It's a lifesaver for sensitive patients.
That is a masterclass in using half-lives to your advantage.
Ah.
Okay, let's take all of this. The complex receptor affinity, the prefrontal dopamine boost, the cardiovascular risks, and the intense withdrawal mechanics, and apply it to one of the most challenging PTSD populations a practitioner will ever treat.
The combat veterans.
Let's talk about combat veterans. How does venlafaxine Effexor actually perform in this specific, highly treatment-resistant cohort?
Combat veterans present a pharmacological challenge that tests the limits of any prescriber. Their clinical presentation is deeply, deeply entrenched.
It's not a simple presentation.
Not at all. They often present with exceptionally high baseline hyperarousal. Their nervous system has literally been trained for warfare and survival. They suffer from profound physical and mental fatigue, sleep architecture that has been destroyed by decades of nightmares, and intense, explosive irritability patterns.
Because their trauma isn't just a single event.
Exactly. It is chronic, repeated, and heavily layered with moral injury.
So do SNRIs have a demonstrable advantage here over standard SSRIs? Because SSRIs often seem to just bounce off this population entirely.
But they absolutely have an advantage, and the literature strongly supports it. Let's look closely at the landmark Zasuk study.
I love this study.
It's fascinating. The researchers designed a trial specifically for a population of combat veterans with severe, entrenched PTSD. But here's the critical detail that establishes the stakes. These were not medication-naive patients.
They weren't fresh off the street.
No, these veterans had already failed a minimum of 3 previous, adequate, entirely distinct medication trials. They were the absolute definition of deeply treatment-resistant.
I mean, failing 3 separate trials means these veterans have likely spent years suffering through side effects with zero relief. Their hope is practically non-existent at that point. What did the researchers do?
They administered venlafaxine Effexor, and they didn't play it safe. They utilized the full spectrum of the multi-stage rocket. They pushed doses ranging from 100 milligrams all the way up to 600 milligrams per day for certain patients.
600 milligrams. That is pushing well into the heroic, DEED-inhibiting territory we discussed earlier.
Yes, pushing up to 600 milligrams is incredibly aggressive.
What were the clinical results of that aggression?
The results were highly significant. They observed a 32% reduction in overall PTSD symptom severity scores.
In a population that had failed 3 prior trials.
Exactly. We are talking about statistically significant reductions in intrusive thoughts, profound decreases in avoidance behaviors, meaning they were actually leaving their homes and engaging with society, and a marked reduction in hyperarousal.
I want to contextualize this for the listener. Achieving a 32% absolute reduction in symptoms in a veteran population like this is not just a statistical blip. It is a massive clinical victory.
It is
It
life-changing.
means getting a father back to his family. It means the veteran actually holding down a job again.
Exactly.
But there is always a catch with the specific population, right? The pharmacology works on paper, the efficacy is there in the data, but the reality of clinical practice is much messier.
The massive catch is adherence. Keeping a combat veteran on this medication long enough to reach those therapeutic, heroic doses is exceptionally tough. Remember the side effects we discussed: the severe early nausea, the intense sweating, the sexual dysfunction, the initial jitteriness.
Yeah, that early activation.
Veterans with high baseline irritability and a deep inherent distrust of medical systems are incredibly quick to abandon a medication trial if the early side effects are harsh. If they feel jittery and nauseous on day 4, they will throw the bottle away.
And because it's Venlafaxine effexor, they will experience a micro-withdrawal.
Exactly, which just confirms their suspicion that the drug is poison and the prescriber doesn't know what they're doing.
Which perfectly leads us into the most common clinical mistakes prescribers make. We need to summarize the major pitfalls so our listeners can actively avoid them when working with complex trauma. What is the #1 error you see?
Pitfall number 1 is chronic underdosing.
Leaving them at stage 1.
Yes. A prescriber starts a patient on 75 milligrams, leaves them there for 3 months, and assumes the drug failed when the patient's fatigue and emotional numbing don't improve. You never reached the norepinephrine effect. You never recruited the prefrontal cortex. The rocket never left the atmosphere.
Pitfall number 2, misinterpreting side effects as treatment failure.
Exactly. A patient calls the clinic on day 6, complaining of feeling activated, jittery, or sweaty. An inexperienced clinician assumes this means the SNRI is worsening their hyperarousal and immediately pulls the plug on the trial.
Instead of coaching them through it.
Right. You have to anticipate this, educate the patient beforehand, and coach them through the temporary discomfort to reach the long-term serotonergic and noradrenergic regulation.
Pitfall number 3 we've hammered, but it bears repeating. Failing to monitor blood pressure. If you are pushing a trauma patient to 225 milligrams or higher, it is dangerous negligence not to mandate regular blood pressure checks. You cannot just assume their heart is handling the vasoconstriction safely.
Fully agree. And pitfall number 4, allowing abrupt discontinuation.
Oh, the brain zaps.
Whether due to poor prescribing strategy, failing to write a bridge prescription, or a patient deciding to stop on their own, the resulting withdrawal is catastrophic to the therapeutic alliance. You must aggressively manage the taper.
So, to really synthesize this entire deep dive, I want to ask the ultimate clinical comparison question. If you have a brand new patient in front of you right now, presenting with severe, functionally debilitating trauma symptoms, how do you decide between starting with an SSRI, like sertraline, Zoloft, versus jumping straight to the heavy artillery of Venlafaxine effexor?
It comes down to respecting the protocol while carefully evaluating the specific symptom presentation. SSRIs, specifically sertraline, Zoloft, and paroxetine, Paxil, are still the absolute first-line starting point for a new patient.
Because they're safer.
Right. They have the FDA backing, they possess a significantly wider margin of cardiovascular safety, their withdrawal profiles are far more manageable, and they just have better overall tolerability. You always start there. You establish the baseline.
But when do you pivot?
SNRIs drastically outperform SSRIs when the patient's PTSD proves to be treatment-resistant. If their clinical picture heavily features profound, crushing fatigue, severe psychomotor retardation, and deep emotional numbing, or if they're simply stalling out and showing only a 10% or 20% response on maximum doses of SSRIs, that is when you pivot.
That's when you pass the brush.
That is when you initiate the cross-taper and bring in the targeted noradrenergic and dopaminergic power of the SNRI.
Let's summarize our main takeaways for the clinician listening today. Venlafaxine effexor is undeniably a heavy hitter in your psychopharmacology toolkit. It is a highly dynamic, dose-dependent
The
medication.
multi-stage rocket.
Exactly. It acts as a standard SSRI at the lower doses of 75 milligrams. It evolves robustly into an SNRI at 150 to 225 milligrams, and it acts as a localized, highly strategic dopamine booster in the prefrontal cortex at the heroic doses pushing toward 375 milligrams.
It's beautifully complex.
It really is. It has the power to bring the brain's executive control center back online, re-engaging a traumatized patient's ability to regulate their own fear response. But it demands absolute clinical respect. It requires careful baton pass cross-tapering, relentless patient education regarding the severe consequences of missed doses, and diligent, ongoing cardiovascular monitoring.
It is a profoundly powerful second-line option when wielded correctly by a highly informed clinician. It can literally rescue a patient from the abyss of treatment-resistant trauma.
But as we look ahead to our next deep dive, we have to acknowledge a massive limitation in everything we've discussed today.
The nighttime.
Exactly. While the daytime symptoms of trauma, the fatigue, the emotional blunting, the lack of focus, and the poor vigilance can be effectively managed and re-regulated by the calculated norepinephrine boost of Venlafaxine effector, the nighttime is a completely different battleground for a trauma patient.
It's a completely different neurobiological state.
Once the sun goes down and the patient tries to sleep, the rules of neurobiology shift. So next time, our deep dive will pivot entirely to the night. We will focus on targeting the autonomic terror of nightmares and the fractured sleep architecture in PTSD. We will be looking at highly specific, targeted medications like the alpha-1 adrenergic antagonist prazosin minipress.
And this raises a final, vital neurobiological paradox for you to mull over as you head back to your clinic or review your charts today. We have just spent the last hour discussing in extreme detail how artificially boosting daytime norepinephrine can improve executive function, clear the brain fog, and fundamentally reduce daytime PTSD symptoms.
Right.
But at night, a sudden massive surge of central norepinephrine from the locus coeruleus is exactly what causes the physiological terror of trauma-related nightmares. It is the adrenaline spike that wakes the patient up screaming, drenched in sweat.
So how is it that the exact same neurochemical that helps heal and regulate the brain by day utterly terrorizes it by night?
We will explore the mechanics of that exact paradox and how to chemically block it next time.
Until then, remember that the diagnostic landscape for complex trauma might be incredibly murky, and there is no simple X-ray to show you where the neurobiology is broken. But with a precise, uncompromising understanding of receptor pharmacology, you have the exact tools needed to navigate it and pull your patients out of the dark. Thank you for joining us on this deep dive.